All right. So now I'm going to introduce our next three speakers and play their pre-recorded presentations. So this is going to be entering a session on reimbursement, and then we will get to some other regulatory things at the end. So Tom Scully is a general partner with Welsh, Carson, Anderson, and Stowe, the most active U.S. private equity investor in healthcare. In addition to his portfolio companies, Mr. Scully also serves on the board of directors of the Health Management Academy, who provide research, knowledge sharing, and leadership development to leading U.S. health systems. But before entering private equity, he was the administrator of the Centers for Medicare and Medicaid Services and the president and CEO of the Federation of American Hospitals. And he had an instrumental role in designing and passing Medicare Part D and Medicare Advantage legislation, and initiated the first public reporting and disclosure for comparative quality among hospitals and other healthcare providers. And he'll deliver a special lecture on reimbursement through the eyes of CMS. Dr. Jill Hagencord is the Chief Medical Officer of Optum Genomics. She's a board-certified pathologist with subspecialty boards in molecular genetic pathology and an additional fellowship in pathology and oncology informatics. She specializes in the development, validation, and implementation of novel health technologies, as well as coding, coverage, and reimbursement issues for novel tests. Prior to joining Optum, she was the chief medical officer of several Silicon Valley genomic companies, including 23andMe. And she will deliver a special lecture outlining reimbursement criteria from a private insurer's perspective and discuss how United Health Group uses evidence and economics to make clinical reimbursement decisions. And then you'll hear from Dr. Mike Broad, who is Data Strategy Director at the Focused Ultrasound Foundation, and he will present the basics of procedural reimbursement and its impacts on specific stakeholders, explore the landscape of global focused ultrasound coverage, and highlight the Foundation's efforts in this area. So enjoy the presentations.
Hi, my name is Tom Scully. I'm proud to be a member of the council and consider Neil to be a good friend. I've gotten to know him over the years and very happy to be as supportive as possible. The reason he asked me to talk about CMS this morning is once upon a time, many years ago, I was the CMS administrator. So I was actually the HICF administrator in 2001 for George H.W. Bush, and then I changed the name to CMS right after I got there. I was there for about 3.5 years running CMS back then, and for the last 19 years, I left in 2004, last 18 years, I've been a partner at Welsh, Carson, a New York private equity firm, and we're probably the most active U.S. healthcare investor. So happy to talk to you about this morning. Other backgrounds: before that, I ran a hospital association, the Federation of American Hospitals, which is HCA and Tenet and all the for-profits. I was the CEO of that during the 90s, and I was President Bush Senior's healthcare advisor in the White House, an OMB for 4 years during the first Bush administration, 89 to 93, and worked in the Senate for many years for that. So I'm old, and I've been dealing with CMS for a long time. So Neil asked me to give you a little background about CMS and how they think about focused ultrasound. And the bottom line is they don't think about focused ultrasound. It's a wonderful agency. I still spend some time up there. I'm very friendly with just about everyone that's had that job, including the current administrator, Chiquita, who's wonderful. It's a giant place, has 6,000 employees that work there full-time in Baltimore and 10 regional offices. About 50,000 contract employees, which I'll get into, who are called Medicare administrative contractors. There's 12 of them around the country that basically run Medicare, largely working for Blue Cross plans. In fact, over the years, quietly, Blue Cross of Florida has bought up the bulk of them. So there's 12 of them that basically contract for CMS to run Medicare around the country, and they make a lot of decisions that affect this. So does CMS sit around and think about focused ultrasound or any new treatment? No, they don't really. You have to bring it to them. So you can get approved from FDA as long as you like. And FDA can approve a new device or a new treatment, but that doesn't mean CMS is going to pay for it. And the system, I think, is very fair, but it's very complicated. It's essentially set up on the premise that you've got to show them why you need to get paid more than some existing treatment out there. And it's quite a high bar for a variety of reasons, mainly that over the years, everybody wants more coverage for everything in CMS and Medicare, and the program is growing like a weed and is very expensive. And so generally there's a feeling that we don't want to cover new things because everybody wants to get paid for more all the time. And there's never a shortage of physicians or other practitioners or hospitals or outpatient centers. Nobody's asking to come in and get paid less or for fewer things. So it's a bit of a high bar, as it probably should be. It's not simple, and it's a complicated place. So CMS process is generally, in your case, I think it'll be covered mostly by the 12 max Medicare administrative contractors. So each one of those is generally a Blue Cross plan. As I said, most of them are quietly subsidiaries of Blue Cross of Florida, about over half. But those 12 regional Medicare administrative contractors make lots of coverage decisions. So they may decide on their own in the Southeast or the West or the Northeast, wherever the region is, to cover a new focused ultrasound treatment under existing code and allow Medicare to pay for it. That doesn't mean commercial payers are going to cover it. Doesn't even mean that Medicare Advantage, private Medicare plans, which is now almost 50% of the Medicare program, program I had a lot to do with designing, are going to pay for it. It's only Medicare. But generally, since most of these docs that make the coverage decisions for local Medicare administrative contractors are working for a Blue Cross plan, and someone after me is going to talk about this United, generally the private insurers tend to cover Medicare. It's hard for them to say no if Medicare covers it. And it basically gives them an excuse and a reason they cover it if Medicare does. So frequently the Medicare decisions are the leading edge for everything else. So generally, when you come with a new treatment like focused ultrasound, you may go to FDA and get it approved. And that means absolutely nothing for getting paid. It just means that it's safe and effective to be used in the United States. It has nothing to do with payment, which a lot of people don't understand. Then they get mad at CMS for not paying for it. Well, CMS has a very complicated process to pay for it. So your first track generally is to go to a regional Medicare administrative contractor and say, look, this focused ultrasound is wonderful for treating a new tumor that hasn't been covered before. And they can on their own decide to cover it, but it's generally covered within an existing payment code. So as most of you probably know, I know the focused ultrasound can be covered in inpatient or outpatient, or in some cases a physician's office. There's three totally different pots of money and three totally different processes, whether you're trying to get paid for it as part of an inpatient hospital procedure, as part of an outpatient hospital procedure, or in a physician's in a clinic, outside of either one. And they're all totally different. They generally overlap a little bit in the coverage decision, but the pots of money are totally, completely separate. So if you go to a hospital, try to use focused ultrasound, let's say in a cancer patient, generally, you're going to have to get that treatment approved as safe and efficacious by the FDA and as being okay to provide as part of a payment for CMS, but it's going to generally be covered under an existing cancer code. So let's say it's uterine cancer. They're not going to pay you a separate amount. They're going to say, okay, that's an acceptable treatment under your bulk DRG or diagnostic related group of Medicare to pay for as part of a uterine cancer if you're at Cleveland Clinic, and that's going to be acceptable. They're not going to pay you more. You can go back for treatment and apply for a temporary add-on code for 3 years if you can convince CMS, which is a national coverage decision, that this treatment is so important on top of other cancer treatments that they should carve out a separate payment code for 3 years, which they can do on the hospital side and track it. Doesn't happen very often. It's very high bar again. And they cover it for 3 years, and at the end of 3 years, if they think the data is good enough, they will add on a new DRG that will say, for example, uterine cancer with MRI plus focused ultrasound. So you can get an additional payment. That's the only way to get it done on the hospital side. And no matter what you do, you're going to get paid as part of the hospital DRG. On the outpatient side, there's a separate payment system for outpatient, very similar process. You have to get approved for the specific treatment to be part of an existing code. You can get what's called the pass-through code for 3 years. Well, CMS will pay more. Just to give you an example again, let's say it's an MRI with a focused ultrasound add-on. They will pay for that if you make the argument and convince them this is an absolutely unique and underpaid diagnosis. They can give you a code and pay you for 3 years. Again, very difficult. Entire staff that looks at this at CMS. And they will give you a new code for 3 years. And if they agree at the end of the 3 years that this is unique and you need to pay more, they will carve out an additional code for you on the outpatient side. Not easy to do. You have to show it's a substantial improvement in treatment, that it's new, that it's not covered, and shouldn't be covered under the bundle. So as you can tell, and I'm sure you're all aware, CMS is really moving heavily towards bundled payments. So whether you're in the hospital side and the inpatient side, or they're on the outpatient side, they're trying to pay people a bundle. They don't want to get into paying for specific sub-treatments. They want to give you an oncology bundle for uterine cancer or breast cancer, whatever. So here's the overall payment bundle. Call me in 6 months. They're a long way from getting there. A lot of stuff is still fee for service, but that's where they're going. And that's why they're hesitant to do no carve out codes. The third way you get paid is in a physician's office. So you probably know, comes down to a thing called the RUC, which is essentially crazy operation where they basically have a council like a UN of docs, which was created again while I was involved. Never should have let it happen. It's basically a subset of the AMA. You have to go to the RUC and argue to them that you need a new code. And it's essentially a budget neutral pot. So if you're out there looking at the couple $100 billion that we spend on physician payments every year, and you want to add on a new physician payment and a new facility fee, both, by the way, are covered in this, under Medicare Part B, you have to argue to create a new code. And there's 66,000 some codes, and they all have to be in roughly a zero-sum game, from everything from brain surgery to a primary care visit. I'm sure you're all familiar with this. You need to get an RVU and a code that pays for this. And to do that, you have to show that you're a new and wonderful treatment that deserves a code. But if they add this into the pot, they're carving it out of somebody else. So there's a lot of hesitation for the physician community, where you can imagine you're sitting around a table with gastroenterologists and urologists and surgeons, and that's the way the RUC works. They make a recommendation to CMS. CMS doesn't have to take it, but they don't have enough staff to do it otherwise. They usually do. You have to argue that focused ultrasound needs an add-on payment and a new code to be paid for. And to do that, you're going to carve it out of somebody else's hide. So you can imagine that is not easy either. So the bottom line is it's a very complicated process. I think it's a fair process. The CMS staff, of those 6,000, probably over 6,000 people that work at CMS now, probably 10 of them are political. Most of them are in Baltimore. This headquarters in Baltimore and 10 regional offices, but the major decision makers are in Baltimore. It's very apolitical. I think they're generally great people. I think they're very fair. They're also very hesitant to add new payments and change. So it's a high bar to go in there and get them to pay for things, as it probably should be. But it's really complicated. So you come in and say, look, we have a wonderful new technology, focused ultrasound, driven by an MRI, and why aren't you guys paying for it? You have to go in and show them why they should pay for it. You got to show them why taxpayers should pay for it. As a general matter, most insurance companies won't pay for it unless you go in there to begin with. So when you think about how does, as Neil said, well, how do you think CMS thinks about focused ultrasound? There is probably nobody at CMS thinking about focused ultrasound at all. There may be, a couple of the regional 12 medical directors who may be friends of some of yours or have a close relationship, or somebody at, Baylor Scott and White or Cleveland Clinic or Harvard has gone in and argued this payment should be there. But it's a grind, and you really have to focus on it, and you really have to get in if you want a separate payment. Otherwise, and it may be fine, you're going to get paid under the existing DRGs and the existing, which are the inpatient hospital codes, and the existing APCs for outpatient payments. And you're going to have to get paid in the physician's office and for under a cancer code that already exists. If you want to get an add-on, it's a lot of work. And I think CMS is fair, and they do a lot of, they make a lot of changes for new technologies, but it's not simple. It's not easy. And nobody should expect people to show up at CMS and say, wow, we just read this paper that you guys printed and we're going to pay you more. It just doesn't happen that way. So it actually is a wonderful agency. I've been out there for 20 years. I don't spend much time there anymore, but I can tell you that I think the career people are really nice and really fair. They have a lot of really good career docs, not enough. But they will listen and they will look at evidence, but you got to have a really focused campaign and a really long outlook on how to get this done. And you're swimming upstream a little bit to get new payment codes, because as I said, their overall trend under Democrats and Republicans, no matter what, the last 15 years has been bundles and bundles and bigger bundles. They're trying to go against more carve-outs and more special payments. And if you're going to treat uterine cancer or breast cancer or bone metastases, whatever it is, and a lot of things I've seen you have covered or trying to get covered, they're not looking for rifle shots. They're looking to put people into more and more bundles and find a way to get you all to treat patients with lots of different technology and treatments the way you see best under an overall capitated amount. So on the other hand, they do like new technologies, and they really think something is significant or dynamic. They will add a new payment, and they will track it, and they will work on it. But it's a bit of a hustle and a bit of a grind. So I would say overall, I'm sure the folks from United are going to talk about this later. It's a really complicated process. It's not easy. No one's going to show up and pay you unless you're really working hard. I've talked to Neil about that. But it's fair. And I think CMS is basically, from a taxpayer point of view, they do a very good job. They tend to be maybe slower than you'd like, but they look at it as protecting the Medicare trust funds and making sure that they're using the funds rationally for beneficiaries as they should. And since I'm going to turn 65 in a couple of weeks, I think that's a hell of a good idea. So anyway, I hope that this is helpful. Neil asked me to give you a little outline. Anybody wants to call me and talk about it, or anybody wants to get more counsel about how to deal with Medicare administrative contractor medical directors who you'd probably be chasing around, or there is a coverage staff at CMS. You can go in and get a national coverage decision and have them, as I said, do a 3-year pilot add-on and give you a different code for payments. It's hard, but I'm happy to give you advice about how to do it or talk to you about it. But I think, as usual, most people in the government are trying to do the right thing. They're usually pretty slow and pretty methodical about it, and that's going to be the case with coverage for your payments. But I think you're at the very beginning of a process where you're very likely to get a lot more attention, a lot more coverage. So Neil has totally convinced me this is the greatest thing in treatment. And so I hope I can help him, and hopefully I can be supportive, and look forward to working with all of you. And thank you for including me in your conference.